Welcome to the fourth part of the Evidence-Based Practice in Athletic Training home study. In this module, we will discuss evaluating the levels of evidence and strength of recommendation for research articles. This will build upon the work covered previously describing the role of evidence-based practice in healthcare, identifying strategies to search the literature, and looking at common concepts that are assessed during critical appraisal. Before a clinician can use evidence in their clinical practice, they need to determine the quality of the evidence, and that is done through an evaluation of the level of evidence or strength of recommendation. We'll first talk about levels of evidence and how useful any medical information is to a clinician is really predicated by the relevance of the information times the validity divided by the work it takes for the clinician to find that information. And that's why previously we talked about ways of searching for evidence using the 5S pyramid and other search strategies that allow clinicians to evaluate and use information that has already been appraised, and in some cases that has been analyzed in the form of a meta-analysis or synthesized into short pieces of information that are easily digestible by the clinician. Using this equation, the best source of information that a clinician can use provides highly relevant and valid evidence and can be obtained with minimal effort. This will allow clinicians to implement the best available evidence for their particular patient and does not require them to spend hours searching for this evidence. If we think of this within the context of goal of information mastery, our target is to really determine the information source that will be the most useful to the clinician. Ideally, you want to work hard to establish validity of the article, which is going to increase its applicability for you to use in your clinical practice. When we talk about relevance, this is going to relate to the frequency of the exposure to the problem, the type of evidence presented, which may be indicated through the study design, as well as the outcome measured that is often classified as disease-oriented evidence, patient-oriented evidence, or patient-oriented evidence that matters. And these terms will become important specifically when talking about one of the grading taxonomies that uses the outcome of interest as the primary category driving force to determine the quality of the evidence. First, if we look at disease-oriented evidence, these are dependent variables or outcomes that typically measure intermediate, physiologic, or surrogate endpoints. These may not reflect actual improvements in patient outcomes or patient satisfaction. Think of these as our ologies, pathologies, etiologies, pathophysiologies. These variables are important in research because they can help increase our understanding of the disease or condition and may include items such as blood pressure, blood chemistry, physiologic function variables, or pathologic findings that one might find during a clinical exam or on imaging. Unfortunately, the information obtained from disease-oriented evidence is often of uncertain clinical utility. For example, if we have a patient who's lacking some range of motion in their elbow, but they are able to function day in, day out, and do the activities that they want, that limitation in range of motion may not necessarily be an important variable in that patient's overall health status. Now, patient-oriented evidence refer to patient-centered variables. These dependent variables or outcome measures are those that patients would care about without explanation. With an athletic population, and one that athletic trainers deal with on a regular basis, this may include return to play or the ability to participate in their sport or physical activity. Across healthcare, patient-oriented evidence can also be seen as morbidity or mortality, symptom improvement or lack of symptom improvement, cost reduction, especially out-of-pocket expenses for patients, as well as quality of life. Now, patient-oriented evidence tends to be higher quality evidence because these variables are things that matter to patients. Now, stemming off of patient-oriented evidence is POEM, or patient-oriented evidence that matters. And this differs slightly because it matters. If it is true, it requires you to change your practice. You might need to change how you are treating a patient to incorporate the evidence from a POEM to improve their outcomes. And this may be different from your usual or standard care for a particular condition. The trick to identifying a true POEM is to decide which outcomes matter to your patient. And we will talk about this in the 6th part of this presentation when we talk about patient values and value-based evidence. For the most part, patient-oriented evidence that matters consists of ready-to-use knowledge that is higher on the 5S pyramid, has already been summarized and synthesized for clinicians. Going back to our equation, the next step is the validity, and this is done through critical appraisal or assessment of the literature. It's not enough for clinicians to accept evidence at face value because of where it was published or by whom it was published. Clinicians need to use different critical appraisal checklists or have a general understanding of some of the concepts presented in the earlier module that discuss how to critically appraise or assess research evidence. So going back to our pyramid of study designs, we see that systematic reviews and meta-analyses are atop the pyramid, as these types of original research take into account and systematically analyze studies on lower levels of the pyramid. Our randomized controlled double-blinded studies, RCTs, are next, followed by cohort, case control, case series, and case reports. Once we move down into the purple and brown shades of editorials, animal research, and in vitro research, these are less practical for application to immediate patient care and typically consist of disease-oriented evidence. So now we're superimposing our study design pyramid with a little bit more of a descriptive element. Our meta-analysis and systematic reviews are typically summaries of clinical research performed by independent investigators to answer a specific clinical question. RCTs are performed with experimental tests of clinical interventions. Our prospective cohort, outcome studies, and case control studies either use hypotheses to predict outcomes or formulate hypotheses to explain implications of a certain phenomenon. While our cross-sectional case series and case studies are typically observational and descriptive studies of clinical phenomenon. As we start to talk about levels of evidence and strength of recommendation, we really need to identify what these two terms mean. Levels of evidence is usually used with individual studies to help clinicians to determine the value of the results reported in that particular study. The grading system for levels of evidence usually ranks from 1 to 5, with 1 being the highest quality level of evidence. On the other hand, strengths of recommendation are used with a body of literature or multiple studies to grade the recommendation for evidence to be used in clinical practice. Strength of recommendation aims to get at how well the evidence answers the clinical question of interest. There are numerous taxonomies to grade levels of evidence and strength of recommendation. And in this presentation, we are going to cover 3, although 2 of them are very similar. The Oxford Center for Evidence-Based Medicine is the most well-known taxonomy. This strength of recommendation taxonomy was developed by the American Academy of Family Physicians and is one that we like because of its use as the outcome variable as the primary driving force in determining a level of evidence. And then the American Academy of Orthopedic Surgeons has derived their scale based primarily off of the Oxford Center scale. However, it is specific to sports medicine and relevant to practicing athletic trainers. If we look at the Oxford levels of evidence, our best level is a level 1, and this contains the best and most unbiased information available. These are often include well-designed randomized controlled trials, high-quality prospective or diagnostic studies, and well-designed cost analysis studies. Level 2 can include non-randomized cohort studies and poorly controlled RCTs. Level 3 is often retrospective case control studies, where level 4 includes case series and poor quality, non-randomized cohort or case control studies. And level 5 is our anecdotal evidence, expert opinion, bench or animal studies, as well as unpublished clinical observations. And so our levels of evidence kind of fall down the pyramid in the same hierarchy as the study design. And the Oxford levels are primarily based off of study design. So here would be looking at the pyramid of our study designs with our well-designed RCTs and prospective studies at the top that will either be a level 1 or level 2. You will note that both for levels 1, 2, and 3, there are notations of a 1A, 1B, and 1C. The A notations relate to systematic reviews. A 1A would be a systematic review of randomized controlled trials. A 2A, a systematic review that primarily consists of cohort studies. And a 3A, a systematic review that primarily consists of case control studies. As we move down the pyramid to our case series and then to our opinion and anecdotal evidence or disease-oriented evidence, we are now moving down to levels 4 and 5. This table is a much larger description of the Oxford Center for Evidence-Based Medicine levels of evidence. In addition to providing the levels, as we discussed previously, stemming from 1A all the way down to 5, this breaks it down by the type of study, whether it is a study of therapy or an intervention, prognosis, diagnosis, differential diagnosis, or economic and decision analyses. Now, primarily in athletic training, we are going to identify studies of therapy, prognosis, or diagnosis. And this really gets at some more defined details about the types of studies that would be included under each of the levels of evidence within the Oxford scale. Now, this is a much simpler table, and this is the strength of recommendation taxonomy. In this level of evidence taxonomy, there are only 3 levels, and they are identified as good quality, patient-oriented evidence, limited quality, patient-oriented evidence, or other evidence. And depending on the study type, whether it is diagnosis, treatment prevention screening, or prognosis, our level 1 is going to primarily consist of systematic reviews and meta-analyses of high-quality studies, or high-quality RCTs or cohort studies. Our level 2 will include systematic reviews and meta-analyses of lower quality studies, cohort, case control, or lower quality diagnostic cohort studies. Interestingly, the level 3, and this differs significantly from the Oxford, is that any other type of evidence, including consensus guidelines, extrapolations from bench or animal research, usual practice, editorials, opinion, or anecdotal evidence, as well as all studies of disease-oriented evidence, fall into level 3. So using the key sort decision-making algorithm, one can walk through to determine whether or not what the level of evidence is using the sort taxonomy. If the study is based on patient-oriented evidence that may include outcome variables of morbidity, mortality, symptoms, quality of life, or cost, then we ask ourselves, is the study based on opinion, bench research, consensus guidelines, usual practice, clinical experience, or a case series? If the answer to that is yes, or that the study is primarily focused on disease-oriented evidence, the article automatically gets a level of evidence of 3. If the study includes patient-oriented evidence, then we determine whether or not it is a systematic review, a high-quality RCT, a high-quality cohort study, a validated clinical decision rule, or a high-quality diagnostic study. If the answer to any one of these 5 is yes, then the article would be assigned a level of evidence of 1. If the answer is no, it is assigned a level of evidence of 2. The AAOS table is more similar to the Oxford, where the levels of evidence are based on the study design indicated in their categories of therapeutic, prognostic, diagnostic, or economic and decision analyses. If we look at rating the strength of evidence for a recommendation, there are again a number of taxonomies that have been developed to allow clinicians to look at a body of evidence, summarize the information in those studies collectively, and determine how strong a recommendation can be made for or against a particular outcome or a treatment to be integrated into clinical practice. The strength of recommendation grading provides a mechanism for clinicians to evaluate research for its applicability to clinical practice. And when we grade the strength of evidence, we should incorporate 3 domains: quality, quantity, and consistency. When we look at quality, we want to know the extent to which a study's design, conduct, and analysis has minimized selection, measurement, and other confounding biases. This relates to an individual study's validity, but we want to look at it collectively across a body of studies that are relevant to a particular treatment, a particular diagnosis, or a particular intervention. We then want to look at the quantity. How many studies have evaluated the question? What is the overall sample size across these studies? What is the magnitude of the treatment effects? And the strength from causality assessment, such as using statistical analyses like relative risk or odds ratios. And lastly, we want to look at consistency, whether across that body of literature, investigations with both similar and or different study designs report similar findings. If we have a group of very well designed randomized controlled trials that hits our quality note, there are numerous studies, that would be quantity, and they all tell us the same thing, that intervention A is better at reducing symptoms related to diagnosis B, then we know that we have a higher strength of recommendation as numerous studies are indicating the same findings across the body of literature. Our taxonomies for strength of recommendation include the Oxford scale, where grade A includes level 1 evidence with consistent results, and grade A evidence means a strong recommendation can be made for or against the use of a particular treatment. Grade B evidence includes consistent level 2 or 3 evidence or inconsistent level 1 evidence, and this is a fair level of confidence for making a recommendation for or against use in clinical practice. A grade of C would be studies of primarily level 4 evidence or evidence that is conflicting, and for clinicians it would be difficult to make a recommendation for or against a particular treatment. Lastly, grade D, or sometimes called I, is insufficient evidence to make a recommendation. So for example, if clinicians see that a specific treatment intervention has grade A evidence, this is probably something they should be doing for that illness or injury as a treatment option, because the evidence supports its use in routine clinical practice. The strength of recommendation taxonomy has an A, B, or C grading. The A is recommendations based on consistent and good quality patient-oriented evidence. A B is recommendation based on inconsistent or limited quality patient-oriented evidence. And grades of C are recommendations based on consensus, usual practice, opinion, disease-oriented evidence, or case series. With the sort, we want to look at consistency across studies. Consistent would be that most studies found similar or at least coherent conclusions, and maybe differences can be explained by the different population or study design. And this may also include high quality and recent systematic reviews or meta-analysis that support a particular recommendation. Inconsistent evidence would be those that include considerable variation among study findings and a lack of coherence, or high quality and recent systematic reviews that do not find consistent evidence in favor or against a particular recommendation. The SORT also has a decision tree for assigning strength of recommendations. First, is it a key recommendation for clinicians regarding diagnosis that merits a label? Well, hopefully, if you're looking up evidence or trying to determine whether or not something would be useful in your clinical practice, the answer to that would be yes. We then ask, is the recommendation based on patient-oriented evidence? If the answer is no, it is automatically graded a strength of recommendation of C. If the recommendation is based on opinion, bench research, consensus guideline, usual practice, clinical experience, or a case series, it would also receive a grade of C. If the recommendation is based off a Cochrane review, U.S. Preventative Service Task Force grade A recommendation, clinical evidence beneficial rating, consistent findings from 2 good quality RCTs or systematic review, a validated clinical decision rule, or consistent findings from at least 2 good quality diagnostic cohort studies or a systematic review, we would give the strength of recommendation an A. If these are not what the recommendation is based on, we would assign a strength of recommendation of B. With the AAOS, they use a taxonomy similar to Oxford, where A is good evidence, level 1 studies with consistent findings for or against recommending a particular intervention. B is fair evidence with level 2 or 3 studies with consistent findings. C would be conflicting or poor quality evidence with level 4 or 5 studies that do not allow a recommendation for or against an intervention. And I is that there's insufficient evidence to make a recommendation for clinical practice. So to close, we're going to look at a couple of examples in practice. The first is a roundtable on hydration and physical activity that looks at consensus statements. And you can see that there are various recommendations provided, along with a level of evidence, as well as references. In this case, because they are using an alphabetical assigning, it would be more appropriate to call that a strength of recommendation rather than a level of evidence. The National Athletic Trainers Association started adding evidence categories for all position statements in 2009 and to the present. So for the recommendations listed at the start of the position statement, you can see here that some are identified as evidence category C or evidence category A. These are assigned based off of the SORT taxonomy. Now what's interesting, specific to athletic training, is if we just take a snapshot of 3 position statements, the 2009 cold, the cervical spine, as well as the pediatric overuse, we can see that of the numerous recommendations made in these 3 position statements, there was a total of 118 recommendations for clinical practice. Of these, only 13% were graded with an evidence category of an A, showing that there's consistent and good quality evidence to either support or refute a particular recommendation. 22% were B, based on inconsistent or limited quality evidence, and the majority were grade C, based on consensus, opinion, or usual practice. I think this is important in really prompting us, as we think of athletic training research, to think of collecting patient-oriented evidence in what we're doing to improve the strength of recommendation and to improve the study design quality so that recommendations for clinical practice can be made on better quality evidence. And if we look at the evidence in the Journal of Athletic Training, this was a snapshot of studies published between 2002 and 2006. 75% of the studies included subjects instead of patients. This means that the majority used healthy individuals to study a particular question as opposed to studying injured patients that athletic trainers would typically treat. 83% focused on pathology or impairment when we talk about a disablement model, which relates to most of them studying variables related to disease-oriented evidence. 75% were controlled descriptive laboratory studies, again, not indicative of studying patients. 88.5% were considered SORT level 3 because they studied disease-oriented evidence. Now, this is somewhat problematic in that this type of evidence does not easily translate to improving patient care and is of limited value for directing evidence-based practice. So in conclusion, understanding taxonomies to grade evidence allows clinicians to determine how much weight to put on this evidence when considering the implementation in clinical practice. Evidence that focuses on patient-oriented evidence is often more applicable to immediate patient care and more valuable for directing EBP. Clinicians need to have a good understanding of levels of evidence and strength of recommendation so that as they begin to evaluate evidence either individually or look at consensus and position statements that indicate higher evidence categories with strength of recommendation of A, that these are things that they are doing typically in their clinical practice. In the next part of this module, we will talk about integration and evaluation of evidence in one's clinical practice, and then finish off with the last part looking at patient values. Thank you.